I'll let everyone just come in because there's still people being admitted. So we'll just give everyone a chance to get in. And I'm delighted to welcome you all to tonight's talk, which is on sustainability in pharmacy and actions, I suppose, we as pharmacists can take to protect the environment. So my name is Ruth McCarthy. I'm a peer support pharmacist here with the IIOP. But tonight, Aisling O'Leary is going to be our speaker. Before that, though, I would just like to mention today is World Pharmacist Day, and that we as pharmacists are meeting the global health needs. And it's good to recognise our international colleagues and ourselves on World Pharmacist Day. So now on to our talk. Oh, domestics. So just to let you all know, this webinar will be recorded. If you could please keep your microphones on mute. You're welcome to leave your cameras on if you would like to. If you have any issues with sound, just check your own speakers are not muted or not turned down. So just check the volume on your own computer. And if you continue to have some issues, try just logging off and logging back on again, and we will readmit you, and hopefully that might address the issue. If you do have any questions for Aisling, feel free to pop them in the chat box as we're going along. And then at the end of Aisling's talk, I will look at those and put them to Aisling on your behalf. We will have a short survey at the end of the talk this evening, and it will be anonymized with any information you put into that. So on to our talk this evening. So our presenter this evening is Dr. Aisling O'Leary, and Aisling is based in the School of Pharmacy and Biomolecular Sciences in the Royal College of Surgeons of Ireland, and she's a senior lecturer there. And at this point, Aisling, if you're ready, I will pass over to you and let you take the evening away. Thank you, Aisling.
Okay, can everybody see my screen?
Yes.
Yep. Okay. Good evening, everybody. Wet and miserable day here, or an evening here in Dublin. To nearly swim into college to actually deliver this. Thank you very much for attending tonight. And I'm speaking on something that I'm very passionate about and I've become very committed to over the last number of years. And my aim tonight is part of that educational piece to actually inform others, because I think that's part of how concerned I am and how much I want to do something about it, is that if one person tonight gets one tiny message and does something that actually helps the environment and the planet that we live in, I'll have achieved my job. So that's what my aim is tonight. Okay, so what I'm going to talk about is very, quite a bit of science, I think, because I think one of the things that really has empowered me to do something about this whole topic is informing myself and educating myself to a great and in-depth detail. So about planetary health and its importance to human health, integral. What are the disruptors to planetary health integrity, and how that is affecting human health, and therefore why the climate crisis and environmental crisis, I'd have to add, it really is a health crisis. And we're not without blame as healthcare professionals and those who dispense medicines every day. So my aim is to highlight to you this evening how pharmacy can and probably or possibly should play a role in sustainable healthcare. And I hope I will have proven that in some way to you by the end, over the next 40 minutes or so. So planetary health. Okay, so this is described as the health of human civilization and the state of the natural systems on which it depends. So that's the definition. Ecology is the study of the environment and things that impinge on it and impact on it. And back in 1971, a guy called Brian Commoner wrote a book called The Closing Circle, Nature, Man and Technology. And in that, he kind of coined the 4 informal laws of ecology. And the first of these is that everything is connected to everything else, so that we have this beautiful balance in the ecosystems. And if something catastrophic occurs to one step in that ecosystem, it can have a detrimental effect on the entire system. The second one is everything must go somewhere. That's consistent with the second law of thermodynamics. Nature is amazing because everything that is produced and the energy and everything like that is recycled. There is no such thing as waste in nature. It does know best. Any major man-made change in a natural system will have an effect on it. And the final one then is that there is no such thing as a free lunch. Exploitation of nature will always carry an ecological cost. So damage to the planet's natural life support systems undermines and reverses progresses that we've made on human health. And if we look at it just briefly, okay, but I think you need to know a bit about Earth systems to really appreciate, and Earth science to appreciate how it has been affected in the last number of years. So if we look at the natural Earth spheres, there are the water, hydrosphere, air, atmosphere, land, lithosphere, and living things, of course, that gives it biosphere, that gives us this amazing, unique diversity of species, and from the very top down to the very bottom, everything that lives together. I mentioned that human health depends on many different things, and the Sustainable Development Goals were developed to enshrine the aims of the populations of the world to better themselves in terms of health and many other things. However, if you modify these into different categories, such as social, economic, and environmental, with the overarching aim of fostering peace and partnerships, although we have a lot of disruption in that at this time of being. If you look at the planetary, the 5P principles then, if you look at the planetary one, protecting the planet and natural resources and climate. So that's life on land, life underwater, climate action, etc., etc. So without that, the economic and social, spheres of the SDGs will not be able to function. And that's absolutely and utterly fundamental. So what is happening and why? Well, obviously, a new sphere has impinged on the planet, and that's us. That is the anthropogenic sphere, the human component of Earth's system. So we're in the Anthropocene era, and this is definitely the era of consumption, because human beings are very much consumers rather than producers, unlike natural ecological processes. So that causes a footprint. This is a paper by Sam Myers, a seminal paper back in 2017, that provides us with the evidence to show what these measures of consumption look like over time. An increase in water use, an increase in plastic production, paper production, primary energy use, and fertilizers and transportation. If you then look at what the measures of human impact on these natural systems are, we have biosphere degradation, marine fish capture, increasing. All of these are on the increase. And of course, we know that carbon dioxide emissions are increasing as well. And in tandem with that, we have deforestation of the tropical forests. And as a result of CO2 emissions, and most of it being absorbed in the oceans, we have ocean acidification. And that then imprints an ecological footprint on Earth and on the planet. I think one of the really seminal things that I have read and appreciated in the last number of years is this paper by Richardson et al. Now, it's based on a framework that was developed in the late 2000s by Ruchström in the University of Potsdam, but it's called the Planetary Boundaries Framework. And it outlines the critical components or boundaries that are necessary for Earth to live healthily, or the planet to live healthily. And in this diagram, we see various different colors, and it's actually called the burning embers type of a representation. So within this safe operating space here, we still have stratospheric ozone depletion, still within a safe operating space. Atmospheric aerosol loading is also there, and ocean acidification, but I'll come back to that in a moment. But human transgressions or perturbations have completely surpassed into the at-risk zones the biosphere integrity, climate change, novel entities, and biogeochemical flows, nitrogen and phosphorus. We can also see here as well that in the zone of increasing risk, we have land system change and freshwater change. So what does this mean? And I'm only going to concentrate on a couple of those or just highlight them for a moment. If we look at biodiversity loss, we know we have mutualists within these ecosystems. And of course, bees are mutualists with the flowers because they both depend on each other. So we're going to see that. So that will have implications in food security, for instance. We have all seen the devastations of waterways and lakes, Lake Blessington, for instance, last year, I know, but these are because nitrogen and phosphorus from fertilizers, etc., and other sources of pollutants have actually got into our waters, causing algal blooms, and thereby disrupting completely the ecosystems under the water because the oxygen is lost from the water, thus affecting fish and marine life, etc., or lake life, as it is in this case. And what's very interesting is that heretofore, novel entities used to be called chemical pollution, but the phrase was changed to the term novel entities to actually incorporate one significant thing that has been synthesized over the last 100 years or so, and that is plastic. The traditional pollutants, oil, gas, and their byproducts from burning them, and then lead, poison, arsenic, some of them have been around for centuries. However, one of the biggest disruptions is actually plastic. And you can see here that it doesn't biodegrade, it has to end up somewhere. And that goes back to that ecological concept that, nature cannot deal with novel entities that has no bearing or meaning in the natural processes of its being. The thing about plastics is that they're not part of nature, as I said, but there's little known of their environmental damage, but we have accruing evidence of its damage, or indeed potential damage to human health. And a lot of this is fed by waste. So if you look at here, we live in a world where we really have this linear economy. We take, make, use, and waste. Whereas we should be getting far more towards a circular economy, our recycling economy. And we'll come back to that when I give some examples in the healthcare setting. The final transgression, of course, is climate change itself, the planetary boundary of climate change. And it is so apparent that the world is warming. And this prompted Antonio Guterres last year to say that we had reached the era of global boiling. And we have gone above 1.5%. Of course, this has been driven by greenhouse gas emissions, and this has actually been prompted or started around the Industrial Revolution, of course. And you think of the wonderful engineering feats and discoveries that were made since that time, but the end product hasn't done the planet or indeed human health any favours either. Just a little bit about global warming potentials and the greenhouse gases. So this, most of the global warming potential is based on atmospheric lifetime of these gases. So we've got everything is relative to carbon dioxide, which is the most abundant, but not the most long-lasting in terms of its atmospheric lifetime. We see here methane, predominantly, but not exclusively, caused from agriculture. We have nitrous oxide, which we use in medicine, obviously, and healthcare. And then you have perfluoromethane, perfluoroethane and sulfur hexafluoride. You can see that the global warming potential in hundreds of years is vastly increased when we come to these other gases. And the hydrofluorocarbons do depend on the HFC type. And again, we'll return to that. The source of the greenhouse gases are well known: burning of fossil fuels, energy use in industry, transport, buildings, etc., agriculture, waste. Waste is a theme that I come back to consistently in this talk, and of course, industrial production of it as well. So we have an ecological footprint and we have a carbon footprint. They go obviously hand in hand. Now, importantly, there are natural carbon sinks, and the natural carbon sinks have been overwhelmed, obviously, as have the other method of removal of the greenhouse gases, which is the atmospheric removal. The natural earth sinks, of course, are forests, where we have photosynthesis, which takes in CO2. You can see, therefore, why losing forest deforestation can then impact on increasing levels of CO2. The oceans absorb the majority of the emissions of carbon dioxide, but that has an overwhelming impact on oceans because they start to rise. That then has impact on humans who live in areas where this impacts on their homes and economies and livelihoods, etc. And of course, then eventually within trees, etc., and biomass, carbon is stored in the soil. The other way of removing these gases is a very important detergent, or atmospheric detergent, which is the hydroxyl radical. However, because we have so many emissions of greenhouse gases, this atmospheric hydroxyl radical has been overwhelmed by levels of the greenhouse gas emissions. And if you think of how this radical is synthesized or manufactured chemically, it requires ozone plus UV light with photolysis to create O2 plus O, and then it reacts with water to form two hydroxyl radicals. Now, they're very unstable and very short-living, but they do an amazing job if there's enough of it around. However, not every substance, entity, chemical that we have synthesized has the ability to actually be broken down by this hydroxyl radical. And recognition of this was taken to task by the Montreal Agreement in 1987, because the hydroxyl radical cannot break down chlorofluorocarbons. And this was recognized, and it was depleting the stratospheric ozone as well at the same time. So these things are important to just remember when we're talking about where do all these greenhouse gases go, etc. So I suppose moving on to what is happening, to why, what are the health impacts of climate change? This is a busy slide, but I'm not going to go into everything in it, bar to say, as a result of climate change, we have climate-related hazards. We're all too aware of the extreme weather events that we're having, the extreme heat events that we're having, the sea level rises I just spoke about, the intense air pollution we've had. Traditionally, we had air pollution many years ago, the smogs of London, etc., etc. That was because of fossil fuel burning. Now we have air pollution from so many different sources. We have differences in vector distribution, such as mosquitoes, and that's changing things. So they're moving from too warm a climate to other climes. So that means that they're bringing disease with them. We're having water scarcity, more droughts. And of course, this is all affecting food security. With regard to vulnerability factors, there are populations that are most vulnerable. And as a point to make is that those in the world that actually release or cause most of the carbon or greenhouse gas emissions are not those that suffer most from it. They're most vulnerable in the world, in low and middle income countries, for instance, who really suffer most from this. But there are vulnerability factors to health hazards or health risks and climate risks that affect certain populations of the overall population. So the exposures then are to people and communities. The health workforce is at risk as well, because we're going to see more conditions being treated, more disasters that we will have to deal with. And then there's the actual long-term side effects or risks as well associated with exposure to pollutants, etc. Energy systems are affected in infrastructure, albeit these catastrophic weather events. And then when it comes to what are the health outcomes that we see, well, directly injury and mortality, obviously, increased heat-related illness. You recall that the Acropolis in Athens, for instance, had to be closed down last year, and I think again this summer, because it was too hot. Too many people were being infected and having heat-related illnesses. We see an increase in respiratory diseases. The pollen seasons are changing. The exacerbation of respiratory diseases, COPD and asthma, from air pollution is very evident. We have waterborne diseases because there's more water, more flooding. We see more diarrheal diseases. We have more zoonoses, vector-borne diseases, dengue as well, of course. We have food insecurity issues. And then because there are direct effects from these exposures in patients, who to all these pollutants, they are actually adding to our portfolio, or to the exacerbations of non-communicable diseases or the increases in prevalence of them. And of course, people who suffer catastrophically from these changes will also have mental health issues, psychosocial problems, dealing with these events, sometimes on a regular basis. And again, health systems are vulnerable because these things can be affected by these weather events and our infrastructure, and then directly on the workforce as well. So it's multiple ways that the health and climate warming actually does affect human health. And if we turn to novel entities, because people consistently talk about climate change in the context of global warming, but if you look at all the chemicals, now, we all new chemicals or novel entities there isn't a register for them. They figure possibly maybe 300,000 novel entities, chemicals, all sorts of plastics have been produced in the last 100 years or so. There's no tracking of these. There's really not any regulation per se. There's been attempts to do so, but they are there. There's no risk assessment done on them. So maybe this is a focus that we should really, really look on, but it doesn't have buy-in, of course. But they do have effects on human health as well. They obviously get into the air, into the soil, and into the water. They enter the food chain. So we inhale particles, we inhale legacy chemicals, radionucleotides, pesticides. All of these novel chemicals, whatever, another way of saying it. So we suffer from, so these are getting into the respiratory tract, into the blood system, everywhere, and being deposited, some of the microplastics and nanoplastics. It's causing cognitive disorders, respiratory disease. They can accumulate in the liver and cause chronic effects. They can cause kidney damages. They can affect infertility and result in fetal inferiority. There's a phrase being, that is well known now of endocrine disrupting agents. So these are affecting key parts of the endocrine system as well, and there's more research coming out on that. So they have an effect on health as well. And this was brought to bear just recently in the New England Journal of Medicine, a study coming out of Italy, where they looked at the carotid artery plaques in which and nanoplastics were detected in patients who presented with, obviously, these events. Where they were detected, they had a higher risk of a composite of myocardial infarction, stroke, and death from any cause as 34 months of follow-up versus those in whom micro and nanoplastics were not detected. So in that paper, you can actually see the actual tiny bits of plastic in the actual plaques that were detected. So I've said how might pharmacists and pharmacy be affected by the whys outlined. You can see that we will have an increased number of diseases, more illnesses. Here in Ireland, we could see different types of illnesses presenting into our hospitals, and more people with respiratory illnesses or allergic diseases coming into our community pharmacies. It will be, become an increasing phenomenon, and has become, obviously, already. So you can see that climate change is a health crisis, all right? And we can see that this has many, many different contributors. Now, one of the things that we have to understand the environmental impacts is we must have data. And data is the source of information, and we have data on so many different things, and even AI is being harnessed for this now. But the pivotal IPCC, the Intergovernmental Panel on Climate Change, brought out their 6-cycle report back in 2023. It made the headlines and news at the time to show, speaking about reporting on the dramatic impact of global warming was going to have. And indeed, and so that provides us with our data. Sorry, there's a light thing going off here. Sorry, I hope you can still see me. It doesn't matter. Anyway, yesterday, a new report came out. Our planet's vital signs are flashing red. The inaugural planetary health check data went back to describing those planetary boundaries and literally made the diagnosis of Earth that it was in crisis, complete and utter crisis. So all the more why we should be beholden and actually feel that we should do something to act upon this. So the first thing as healthcare professionals is that we take care of patients. We certainly don't want to cause harm. But unfortunately, the impact of healthcare delivery does impact on climate change and on the environment as well. We have a burgeoning global population, and therefore we have an increased use of healthcare services, and that's consistent with the consumption issue that I talked about earlier on. So in and of itself, it pollutes and harms and therefore impacts human health. It has a high carbon footprint, so in and of itself, it pollutes and harms and therefore impacts human health. Healthcare is associated with a high carbon footprint and with direct environmental damage. Now, this is just one, way that this is presented here, and you can see that the majority is in the generation and distribution of electricity, gas, and heat or cooling, and that's air conditioning, obviously. operational emissions, and many other factors. Waste treatment, you can see here. You can see them all divided, and this has been calculated in various different jurisdictions. And this is just one example in a hospital of waste from one ICU bed in one day, and this is in a hospital in Holland. So just to show you the plastic, the tubing, and everything like that, the gloves, etc. Now, at the moment, Stephen Walsh is undertaking a Clement Archer PhD here in RCSI with Matthew Walsh and myself, and he has just completed a scoping review of the carbon emissions, or the carbon footprint in primary care. And what he has found, that basically it's non-clinical sources and clinical sources, and you can see them there yourself. Okay, but just to point out that pharmaceuticals are a big carbon hotspot in primary care, because it's one of the main actions that is undertaken for when caring for patients. You can also see here, one of the other things I'm going to talk about a little bit more detail in a moment are gases, which are the propellant gases and pressurized meter dose inhalers. Obviously, there's nitrous oxide as well. And one other point I just want to make here, because travel, you wouldn't, a lot of this has been quantified, but a lot of work of this has been done in the NHS in England. But patient travel to appointments and staff commute to work is also a carbon hotspot. And if you compare that to the hospital, where surgical operating theatres are really the carbon hotspot there. So you can see there's a plethora of different contributions to the carbon footprint in primary care. And we'll be doing other research over the next while as well in this area. Turning to medicines then, again, consumption, a pill for every ill. People are actually, using medicine as a panacea rather than actually alternative methods toward well-being and good health. So medication use is high, consumption is high, and it's rising. So there's increasing levels of polypharmacy. Now, there are other factors, of course, that contribute to that, such as older age demographic, etc., and many more non-communicable diseases as well. The NHS have estimated that the carbon footprint of healthcare system, 25% is due to medicines. And it's also responsible for considerable environmental harm, because an awful lot of our medicines are either packaged in plastic or polystyrene, or we have lots of single-use plastic auto-injectors, etc. now as well. And a lot of people who are prescribed medicines don't take them, and some are prescribed ones that they probably don't need. So there's significant waste. If we look at the upstream sources of the emissions and environmental harm, of course, we have the manufacturing plants, these huge manufacturing plants. Sometimes they're scattered all over the world. We have the plastic use in medicine synthesis. We have solvents, obviously, as well. They can be harmful in terms of effluent here. The packaging, but it is the supply chain. It is enormous, because you can have medicines, API made somewhere, then shipped to a packaging plant, then on so forth, etc., until eventually it gets to the wholesaler on this side. And that continues then, obviously, when it gets from the wholesaler to the hospital and on to the patient. So a Loli capsule, our tablet, has travelled an awful long distance to get to actually being used by a patient. There's considerable amount of overprescribing, as Roseanne Kenny demonstrated in the TILDA data set. We have antimicrobial resistance. Now, we have two things that are causing that: overuse of antibiotics, but also climate change in itself is contributing to that. We have people who do not comply, and then you have to get rid of them. So every medicine that is prescribed and not taken has incurred a carbon footprint from its manufacture, storage, distribution, dispensing, etc. So it's imperative that we do actually use all our medicines, and they have to go somewhere. So used and disposed medicines, the APIs and their metabolites and their excipients, they all end up in our waterways. So they have potential for ecological and human contamination. This has been demonstrated. This is Lake Michigan in the US. And this has also been demonstrated by a study undertaken in DCU. And the River Liffey has been shown to have high levels of various different medicines as well. Oral contraceptive pill, metformin. Look at the medicines that are used for conditions with high prevalence: statins, antidepressants, and all of this. studies have shown that there's blunting in marine life and other parts of the ecological system. The true impact on humans isn't possibly known to full extent as yet, but it's postulated. So, the long-term impact of subtherapeutic exposure, this persistence, bioaccumulative effect, and toxic effect, will it come over time? Because if we take more medicines, we're only going to have more excreted. So the era of ecotoxicology testing, the era of ecopharmacovigilance to be thought about. Also, with these environmental impacts, it also can cause knockout ecosystems. I don't have time to talk about that, but you may be aware of it. And also there's the inability of water systems. They're not set up to eliminate these residues. And obviously lots of antibiotics in water as well. So what's happening? Well, there's a green lens coming on healthcare. It's not that people aren't talking about it, not doing something about it. Well, we have the World Health Organization, we have the United Nations Framework for Climate Change. The next COP is COP29. It is in Azerbaijan. The last one was in, obviously, as we know, in Dubai, not without its controversies. We have the EU climate law, the EU Green Deal. We have the pharmaceutical strategy for Europe, which does mention environmental sustainability regarding medicines. We also have guidelines coming up on single-use plastics in accordance with Directive of 2019. More locally, we have the Climate Action Plan of 2024 here in Ireland. And of course, last year, Philip Crowley launched the HSE climate strategy with its key indicators for change within our healthcare system. And then we have organisations that have looked within and from within the healthcare sector. The Healthcare Without Harm was started in the States in the 1990s. And then a fantastic resource for anybody is the Centre for Sustainable Healthcare, which was set up in the late 2000s in the UK by Frances Mortimer. So she was the one who described the 4 principles of sustainable healthcare. And these are pivotal to what we as healthcare professionals would do, even not considering the environment. But anyway, the first thing, of course, is prevention. Right? Promoting health and preventing disease by tackling the causes of illnesses and inequalities. Because preventing an illness means that people will not need healthcare, will not need medicines. And this can only, better. And also looking at the social issues that contribute to diseases as well, that maybe these are the causes rather than true healthcare issues. Patient self-care, empowering patients to take a greater role in managing their own health and healthcare. So that's that whole concept of, well, it used to be called health promotion, but making sure that patients are preempting progression in their diseases, that they're becoming health literate, taking care of themselves. And then lean service delivery means jettisoning waste in systems and processes, streamlining care, avoiding low-value care that has no real benefit for patients. And then the final one then is low carbon alternatives where available. There's another one, kind of semi-5, which is to look at our operational setups and what we do around decarbonising them and making them more environmentally sustainable. So sustainable healthcare then is the ability to provide healthcare to meet the needs of this generation without compromising the ability of future generations to meet their healthcare needs. The Healthcare Without Harm report roadmap of 2021 succinctly describes what we have to do in terms of preventing further damage, particularly focusing on decarbonisation. So power healthcare, power, zero emission buildings, zero emission transport and travel, healthy diets, low carbon pharmaceuticals, circular economies, circular healthcare, and establishing greater health system effectiveness. In terms of looking at the upstream interventions or pinch points, if you want to put it that way, green chemistry, okay, making reactions that don't require heat, using biocatalysts instead of other forms of catalysts, not using solvents, making reactions water susceptible rather than having to rely on solvents that will require special disposal. Eco-friendly products. I'm just looking here. This is a novel way of delivering vaccine that does not require cold chain that can be just very easily discarded, does not need needles, syringes, etc., etc. So it's a micro needle. There is an environmental risk assessment currently underway through the marketing authorization process, but it needs to be strengthened. We need to identify additional risks at that point of authorization as well. We badly need to look at production and packaging, or packaging in general, and we must look at minimizing pollution risk as well. And post-authorization, eco-pharmacovigilance, gathering data on the issues that may arise when these products or their metabolites get into the ecosystems, and then the health impacts on human beings. In our own sphere then, HTA and health technology assessment, should we incorporate environmental impact into our decisions about cost effectiveness and what we will reimburse? That's at its early stages, but the University of York are certainly doing a lot in this. Matt Taylor over there. And what we need to bring, of course, into businesses is this environmental and social governance stance, around protection of the environment. And that will require reporting, obviously, as well. Can we impact on upstream effect? Well, if we put in some of these interventions that may impact on downstream use of medicines. Green procurement will depend on the greenness of our, what has gone into the manufacture. If we can determine the carbon footprint of medicines, well, then we can take that into consideration when we're looking at efficacy and safety as well. And if we can do that, then we can look at prescribing. We can eco-direct, use eco-directed prescribing, use alternatives to medicines, reduce overuse. Dispensing, again, if we can carbon footprint them, deprescribing, medicines optimization, avoid and reduce waste. Use, optimize use. Make sure that people are taking the medicines that they need. That will avoid and reduce waste. And then in disposal, if we can cut out the waste downstream of this part, we can minimize waste then to going into landfill or elsewhere. And I just mentioned reuse, and I'll come back to that. Okay, so if there's a link here that anybody can access. I think it is publicly accessible, and it's a very good series of articles that is coming out from the BMJ, who are very exercised about this topic. So sustainable practice, what can I do? And you can click over on this part here and you can change what your view is. But this is the principles: avoid, reuse, prevent, low carbon alternatives, system change, communicate and reduce. And they change it then, you can into speciality and you can secondary care versus primary care. Looking at good, news stories. They recognized that anesthetic gases, were a problem. The atmospheric lifetime is dependent on the ability of this hydroxyl radical to break these, and CF is far harder, which is in desflurane. So there's a big move to switch away from desflurane to sevoflurane in the hospitals. And Scotland has been the first country to ban the high emissions of anaesthetic desflurane. Only possible because we could determine the carbon footprint. And this year, the College of Anaesthetists Ireland say they strongly advise its members and fellows to transition to more sustainable anaesthetic techniques. Same, we can estimate the carbon footprint of our PMDIs. You can see here, we have our HFAs, which are the most common at the moment. Look at their global warming potential. It's considerably more than carbon dioxide, but you can see here the CFCs that were banned in the Montreal Agreement, so even far more so. So these are now going to be phased out, and we're waiting for HFA 152A, and even the hydrofluoroolefin is coming in as well. So having that data, we can map. So we can see here a DPI really doesn't have any carbon footprint, except from the plastic, of course. A small volume aeromir or salamol is about 10 kilograms of CO2, whereas a typical 100 or 20 or 200 dose preventer meter dose will have a 19 kilograms. A ventolin or evohaler is up around 28 kilograms per CO2. So you can see that we can actually, mark them as high CO2 and low CO2. So that has brought in, certainly in parts of the world, certainly in the UK, they have a huge drive around this, opportunities to reduce, switch to a salamol low volume, or change to DPIs or SMIs. And this is epitomized by the HSC Inhalers Action Group, which was set up headed up by David Hanlon and Sean Owens, and that is doing some preliminary work on that at the moment. Successes have been apparent in many pilot projects all over the UK with massive savings, and note that it also has economic savings as well. And just very recently, we have a medicine's carbon footprint. It uses a different method rather than a life cycle assessment. But we can see here that you can actually log into this. You can actually sign up for free. And then you just put it in as if you were doing a DDI interaction checker. And you can see whether it's a high, low, whatever it is. This will assist us in making eco-formularies, for instance. You can see that the carbon footprint of antibiotics certainly have a high MCF rating. I've talked about prescribing, but just to reiterate as well that there's also the potential for social prescribing, nature prescribing, but also to decrease interactions, perhaps in the hospital. This was a pilot study done in HIV patients who were stable on their meds to go from from twice yearly to annually to cut down all of the associated carbon footprints associated with getting tests, etc. And that worked out well, and a very, very good buy-in with the patients. Learning to swallow pills is good for patients, parents, and the planet. So you can see here, tablets, I'm sure this presentation will be disseminated, but we can actually teach children as young as 4 years of age to actually be trained, and we can also do it on adults. So it's something that is worthy of looking at, especially for children's hospitals as well. IV over PO, it's another hospital intervention, overuse of IV medicines globally. Higher carbon footprint, more packaging, implications and increased risk of infections, more time from the workforce. We already have a 3-day review for IVOS in antibiotics. Apply that to other therapeutic areas. This is very elegantly shown here in a study coming out of Great Ormond Street Hospital, which shows an 167-fold difference between two oral tablets and a paper cup and an IV prep. Medicines overuse. This, try to eliminate things that have low value. We all know that we have so many patients on PPIs. Looking for anticholinergic burden can be estimated because this has risks for patients as well. And iron deficiency anemia from, changing to once daily or even once every second day, cutting down all the time. So using our patient interaction episodes and our medication review sessions to actually really bring those points forward. Hospital initiatives, I won't go into them. There's so many things, so many novel things. If you just look around and take time in the hospital or even in your community pharmacy, you can see opportunities. I was looking at this paper, I found it there the other day, Optimizing Oncology Drug Expenditure in Ireland by a group in CUH. And they highlighted the need to reduce waste, to avoid futile treatment, to do so by altering drug scheduling, file sharing, dose banding. And they said there was potential for significant cost savings. They didn't mention the carbon savings. That comes with it as well. Reusing medicines is a moot point. We have FMD, but Holland is leading the way in this, and maybe more will come in the future, other ways of doing it. And there's even talk about getting back unused medication and deformulating the API out of it. Quite difficult to do, but there are some studies on it. Waste, what a waste. Optimize waste and recycling across all sectors. Using reusable bins, bio bins, where people can use them and segregate. It's that segregation that actually is really, really important. And in terms of blister packs and other things that are returned to community pharmacy, I'm aware of it. There's a lot of waste that occurs there, but some of that is recyclable. I know that we don't have a medicines return scheme, even though it has been promised, but it may come. I hope it does come in the community soon enough, because we still have all those medicines going into the waterways. Plastic-derived products in healthcare, how can we cut them down? CAD cassettes, speculum. We have plastic, units here, but also the packaging that goes with it. PPE, masks, blister packs here, and gloves. There are so many things that we can do to reduce their use, go to reusable gowns. They're doing that in surgery now, reusable caps, circular economy principles, back to metal, autoclaving, etc. And also when we make trays in hospitals, and open all the vials ready for the anaesthetist or whatever it is, or for surgery, move from just in case to confirm required. So going to that circular economy. And we know There are many occasions where we wear gloves when we shouldn't and we don't need to. Resource use, I think that's fairly clear. Decarbonisation, reduce it. Get rid of our digital footprint, or at least reduce it. Community pharmacy in Wales has been very successful in this. And make patients part of the solution. They are very environmentally aware. And if you start talking to them and making every patient contact count, you will actually see it. Check in their bags when they come in to collect their prescriptions. Do they really, really need everything? Are they hoarding at home? Bedrec in hospital offers opportunities to identify unused medications and also for other issues that may be affected by climate change. So hospital pharmacists, successful at antimicrobial stewardship, medication safety, we have so many pharmacists doing these roles, opioid stewardship, why not extend it to eco-pharmaco stewardship? Very busy slide, I'm not going to talk about it, but there are pinch points in the dispensing process and distribution process that we can actually affect very, very well in community pharmacy. This is from Portugal. A lot of that, disposal doesn't apply to us, but there are opportunities to discuss things with patients and reduce waste as well. Loads and loads of different toolkits out there. Too many, it's actually, you go down a rabbit hole. Just point out the GLOS toolkit from the ICGP is a very nice document. And then we have, how do we go about this? Maybe clinical audit, but apply sustainable quality improvement. And that really shows the value in sustainability. And we have better outcomes for patients and populations, hitting the triple bottom line, environmental, social, and financial impacts. I'm not naive enough to sit here at 10 to 9 and hurry up to finish up, that this isn't without its barriers. We all have issues. There are so many competing interests. We have time constraints, workforce, issues, cost implications. And that's at an individual and at a broader level. There are enablers. If you're motivated, one of you out there tonight. And also we do need buy-in. Maybe seeing results can also help. We do need support though. Education and training. One of the reasons why I'm here tonight and we're trying to embed it, we are embedding it in our undergraduate degree. We need policies. Scotland are ahead of the curve in this with their policy. The role of the regulator. The General Pharmaceutical Council of the UK have come out. Really, the big thing is we need protected and dedicated roles across the health service to deliver on the National Climate Action Plan and the HSE strategy. And this will require transformational leadership. Adopting sustainable pharmacy practice has many, many positive outcomes. So in summary then, when we've turned to other public health threats, we've actually pivoted. We did it in COVID. We did it for the smoking ban. We've done so many different things. So why not for this? I think it's probably, people think it's more an environmental issue rather than a health issue. I hope I've shown that it actually really is a health issue. And we can be real leaders in this and show by example in what we could accomplish by working individually and collaboratively. I've spoken to many people about that and they say, no, well, the big polluters in the world and the companies and everything, really, if they don't change, how can we, make any difference? But it really, really does matter. Every little action really does count, despite what is thought. And we really do, as individuals and as a collective profession, need to become planetary stewards, that other stewardship that we must take under our wing. And perhaps, who knows, someday we'll have our own Irish pharmacists for greener healthcare. So I leave you with those words. And I know I've probably gone a bit over time. I apologise. But thank you for listening. And I hope you've got something out of this evening. And there's a lovely link to David Attenborough there, which a powerful, powerful message that he gave in Glasgow at one of the COP conventions. Thank you.
Thanks, Aisling. That was fantastic. I feel like I'm loaded with information at such a level. There was a lot in there, a lot to digest and reflect on, which is brilliant. And I'm glad we'll be getting the notes afterwards to go through. But if I was in my dispensary and I'm going into work tomorrow after this talk, feeling that little bit inspired, going, yes, there's something I can do. Where do I go or how do I start kicking something off?
Well, competing interest. I said I think one of the things is waste, looking at waste and making sure that what is recyclable is going into the recycle bin. What isn't. If there was one thing. Stock control, I didn't mention it, but obviously that is, not leaving meds, and that goes for both hospital and community
Yeah.
pharmacy, in good inventory control. It's on that very busy slide from community pharmacy there.
Okay.
That man in Wales is actually trying to streamline the suppliers to one so that it doesn't incur all of that. Now, whether that's feasible in the wholesale system we have here, I'm not quite sure.
Okay.
But yeah, and start talking to patients.
Yeah, that seems to be
Yeah.
like the low-hanging fruit, as they call it, an
Yeah.
easy one to just get ourselves doing, one, if we took away one thing or did one thing tomorrow when we go back into work, that we would action. I have a question here from Jennifer. She's thanking you for your lovely presentation. You mentioned reducing the IV-ABX bags as a way of reducing plastic waste. Is there any emerging evidence to show that this might also reduce the microplastic burdens in our bodies?
Well, there are some innovative ways of trying to grab the microplastics and stuff that are in the oceans and in the waters. In fact, there was one young fella down in Cork that was doing it. That had a very novel way of doing it. We're a bit overwhelmed at the moment. I think the science is going to come and going to show that, but any reduction at all. Does anybody know how long it takes for a plastic bottle, for instance, to biodegrade or degrade? Does it biodegrade? No, it doesn't really.
Few
One
hundred,
plastic bottle.
few hundred years? I
It
don't
doesn't
know.
degrade by biotic processes. It actually does. It's sunlight, and
Okay.
it takes hundreds of years. So one thing that very easily we could do. I don't buy, well, literally no plastic bottles at all now.
Okay. Welcome to UCC, plastic free campus. Went to get a coffee today and I realized I didn't have a recyclable cup. So that wasn't going to happen. No coffee for me. I have a question here for Hazel. Does anyone know, are the empty, the strips, the blister pack strips that we have, the kind of aluminium ones, are they recyclable?
Okay, yeah. Stephen, actually, our PhD student, actually was looking at this, and I know EnviroFarm have biodegradable products and stuff like that. He thinks that there is the potential for them to become a part, but we actually need to do some more work. There is a forum on the Centre for Sustainable Healthcare for Pharmacists where this discussion is ongoing. And actually, Stephen, may prepare something and may do a little bit more work for that we could actually distribute something for community pharmacists as a quick guide. And that's something that he's going to work on, I think.
So at this point in time, they don't go in the recycling bin.
No,
No.
like
Okay.
even to pull them apart to take the foil off might be
Yeah,
difficult.
very
Although
difficult.
he has
Yeah.
said that it is feasible. But
Okay.
again, we
Okay.
can come
So
back with some if there are questions that I need to get to after.
can I pick your brain there? You mentioned embedding it into the undergraduate program so that the next generation of pharmacists coming out would have a greater awareness. What does that look like, or what elements will you?
Okay, so at the moment, well, there's a lot of work going on in a lot of the colleges. So what we have done here is that we started an optional module in year 2, just in the new farm program. So I started that a couple of weeks ago. I had them all presenting this morning on mitigation strategies, cosmetics, fast fashion, bringing them, and diets. They had absolutely no idea. I'm letting them do it themselves so that they can see it. With regard to embedding it across curricularly, that's going to be more difficult. So you have to go into systems. So we take endocrine system. So if we have patients with diabetes, in the patient history, consider the environmental factors. If it's heat, they're going to get increased issues with that. So they might, and kidney disease. So in the, kidney, cardiovascular, of course, hugely heat sensitive disease as well. So embedding it across like that. I know that in Trinity, they're doing huge work at an institutional level around this as well. And Cecily Roach is part of that team that are looking at that. And I'm sure yourselves, and of course, you've got a big sustainability group down in UCC as well.
We do. Yeah, it's embedded. No plastic bottles are allowed on campus. Everyone has to bring their reusable bottle, and it's amazing how quickly you it becomes normal. And in the beginning, we were all like, "What?" And now it's part of our everyday. So you do adjust quite easily. We have a lovely tip here about the methadone Martindale, how you can wash out the bottle and reuse it for your weekly dispensing. So that's an excellent suggestion, and one everyone can take away from tonight as one simple action that we can all action tomorrow when we go back into work. If no one has any more questions, I don't see anything else coming through on the chat box there. Thank you again, Ashleen. That was a really,
Problem?
really wonderful presentation. And just to remind you all to, if you could take a few moments now to complete the survey for us, just to give us a little bit of feedback, that would be wonderful. This evening, and maybe after you finish the talk, it might be a moment to do a quick reflective cycle and put it into your CPD portfolio, looking at what you've learned today, and I suppose ultimately evaluating your impact in practice. What will you do differently tomorrow on foot of what you've learned from Ashleen tonight? And then looking forward to our next webinar, which will be on the 9th of October, we'll have Jennifer McCartan coming in from the HPRA, and she will be talking about the medicine shortages as she leads that up from the HPRA. So we really look forward to seeing you again on the 9th. Ashleen, thank you so much for your time this
Problem?
evening. It was a wonderfully inspiring talk and definitely has given us plenty to think about. And we could all go to work tomorrow and do one thing different, even if it's just on the waste. Thanks so much. And thank you all for dialing in. We really appreciate it. And we look forward to seeing you all on the 9th. Thanks now. Good evening. Thanks, Ashleen.
Stop.